everybody is on the same page。我就请到了。
好，第一个是一个54岁妇女的子宫颈膜片，然后它上面只有写说它是 routine 的 examination LMP， 没有写有做过 hysterectomy 这样子。看一下这个片子。看起来它有一些 intermediate cell 跟 superficial cell，suppose 它可能还没有停经，或者是有在吃什么荷尔蒙的药物，让它的squamous 能够成熟到表层。那这边是比较多细胞的部分，在这个除了有细胞之外，背景有一些菌，然后还有一些可以看到这种很像裸核的这种东西。然后放比较稍微高倍一点看的话，就有看到很像是有中间有一个 groove， 好像疑似还有点状核的出现，在这边这种。然后它的数量也蛮多的，这边的点状核可能比较明显。然后是
视野的正中。
这边，这颗可能相较是比较清楚的，这里有一个很像点状核的，然后下面这里也有一个比较清楚的，背后有一些杆菌的一些干扰这样子。所以这一个的话，我最后是打它有 microorganism 的 infection， 觉得是 trichomonas 这样。然后它的数量也蛮多的，如果今天有 microorganism 的 infection， 可能数量都会比较多，然后有一些发炎的状态。那这个数量都不少，在这个细胞的周围，只是它有一些杆菌干扰，所以看的不是很清楚。但是放到高倍之下，就看起来都有微微的这个点状核出现。
所以这个形态应该算是清，虽然染色有点退掉，
对。
然后重点就是它好像有那个核仁，就是一点一点的核仁的出现。再来就是你可以看到那个左下方看起来细胞，不要跑掉，刚刚往上，往上，再往上，再往上。好，现在荧幕的左下方，这里其实就是它好像把细胞吃掉，有那种 cell lysis 的样子。所以其实看起来好像它是有在作用的，所以这个应该是打 trichomona 应该是合理的。只是我们应该是说 trichomona 在的时候，理论上乳酸杆菌不会这么多，因为它的那个 pH 值会不一样，它不会让它这么就是乳酸杆菌这么多，是有一点奇怪。可是因为它背景的那些东西的大小，它的形状，然后还有出现 groove 跟这个点状核仁，所以应该选 trichomona 是最合理。所以这题应该这样，我觉得是 OK。好，
那我们进到下一题，第二题。第二题是一个60岁妇女的子母，她有 postmenopausal bleeding， 然后 LNP 没有写，这样。那这个片子一放下去，虽然它褪色的很严重，但是可以看到有成片成片的细胞。然后在这个视野之下，放到比较高倍看的话，有些核都特别的大。然后成团的这个细胞里头，放到更高倍视野看，就有发现说核的大小层次非常的厚。然后有蛮 cross 的 chromatin， 排列的话也不太一致，有垂直的方向性。所以这一整个来看的话， 而且它在这成团的边边可以看到它有 glandular 的 polarity， 所以看起来的话比较偏向是腺体的病变。然后再看到其他这个视野，可以看到这个细胞层次很厚，排列的很紧密，然后边边比较没有重叠的地方，这边疑似还有一点 molding 或者是 vacuole 的感觉，然后大小都很不一致 ，nucleus 的 contour 也不是圆形的，看起来都形状很不好，所以看起来恶性应该没问题。再加上它排列性是 glandular 的，所以看起来是一个 adeno 的状态。然后背景有蛮多像这个很像是 mucus 的分布，所以有可能它是 endocervix 的 adeno。另外
case 看起来应该是直接抹到的哈，但是因为你看它的量非常的多，然后它的细胞的 preservation 都非常好，然后 size 都很大颗，所以看起来应该是直接抹到的，所以它的病灶应该是在 cervix 有被抹到。那刚刚看到的那些看起来没有很像 mucin， 因为 mucin 不会这样粉粉的，它应该是一整块，然后把它推出去，所以那些可能是一些就是 degenerative necrotic 的一些 debris 或是一些东西。那我自己觉得这个 case 有一点讨厌，就是说虽然它的结构上看起来就是很立体，然后好像边缘有一些地方有比较像 glandular 的样子，可是它整体看起来是 hyperchromasia， 它的 chromatin 事实上还蛮粗的，然后再来就是它的核仁没有那么的明显，然后再来就是说它里面有一些单颗细胞还是有一些 spindle 的形态，所以这个到底是 square 还是 adeno？ 我觉得它如果到时候出来不是 adeno， 好像也没有说不可以啊。可是我们因为考试，我们还是要选一个最符合的答案吧。好，所以这个可能停经后出现，然后adeno 可能是最有可能。那再来就是说，如果是 adeno 的话 ，cervix 的好像没有那么像，这个是不是比较像是 endometrium 吃出来的？因为 cervical 理论上我们会比较多 mucin， 所以到底是从哪里出来的，有点不太清楚。对，不过如果要选 adeno， 我觉得应该是合理。可是如果出来不是 adeno， 我觉得也不奇怪，因为它整体的形态，你可以看到，可以再晃一下，看到其实有些地方好像很明显的，刚刚有那种 cell in cell wrapping， 然后它的大团的边缘也有一些 spindle， 然后整体看起来是比较 hyperchromasia。那有些单颗的细胞也是，不过因为没有看到角化，所以我们选 adeno 还是比较合理，所以这题我们选 adeno 应该是 OK 的。
第三题是一个22岁女子的子母，然后印象这个异常的细胞非常少，比较偏靠下面一些，然后这个细胞的分布很符合她的年龄，22岁的女性，有很多的 superficial intermediate cell， 然后有些 intermediate cell 里头还有这个黄黄的 glycogen 在胞浆里面。
所以它的这种 glycogenetic 的 intermediate cell 其实量非常非常的多，22岁感觉很奇怪，所以这个其实看起来感觉它应该有在吃避孕药，就是黄体素的避孕药，所以它的这个子宫颈的抹片才是长这个样子，不然我们一般22岁的女生她的 intermediate cell 不会有那么多 glycogenetic 的细胞。那这个大家打都写，这个我看不到，我不晓得在哪里。
对 我
你在哪里？我没
对
有看到。
我要找一下，因为我记得它数量非常少。没有打点就比较难找到它在哪。一时找不到它在哪里。
等一下，再麻烦点一下好。不过右尾说是 ask us high， 我有看到有一些我觉得很怀疑是还是有的戏法。这题请 screener 再点一下，因为 Lucy 我真的一颗都没看到，再麻烦 screener 确认一下。
好。
我们今天结束前把答案再送出去。
好。
所以请 screener 再帮忙点一下，因为所有人都打 Lucy 除了右尾，可是我一颗 Lucy 都没看到，可是我有看到真的很像 ICO 的戏法，请大家再点一下。
好，那先进到第4题，第4题是47岁女性的子母。然后这一个的话，看起来很多 superficial cell， 这个答案是打 Candida， 在这边就有看到一个很像 pseudo hyphae 的，这边有一些，这题就比较简单，有budding，然后出芽。比较清楚这边，然后budding，然后小小的 pseudo hyphae 有出现。最后一题是44岁妇女的子母，她说她LMP 是第15天。那这个的话是没有看到什么异常的 precursor lesion 或者是 microorganism， 所以这一题我是打 negative 这样子。
这片我隐约有看到一些双核的戏法，所以其实我有点不晓得第5题跟第3题到底哪一个是 negative， 哪一个是 precursor， 所以可能这2题再请大家帮忙点一下，
好，
确认一下到底有问题的是在哪里，是哪一片。
好，
你看现在这边就有一些双核，所以再麻烦点一下。
好，
好 ，OK， 那就谢谢。所以再麻烦大家最后那个考卷检讨，然后我们已经要delay了，所以请大家拿到了就赶快看完，赶快给我。谢谢包容。下一次换惠芝，好。好。So we have a couple effusion specimen. So the first specimen is a peritoneal washing specimen. The patient received colectomy because he had colon cancer, and this specimen was acquired during the surgery. So the screener has highlighted some cells. In the background, you see prominent acute inflammation, and the screener has highlighted some cells. So we do see these very, very dark pigments in some of the cells. However, the cell does not have any atypia. It looks like a histiocyte. So what are these very dark particles? So when we do the colon scope, If the clinician see there is a lesion, highly likely to be an invasive cancer, they will usually do a Indian ink injection on the site of the tumor. So when the surgeon go into the stomach, then can identify where exactly the location is the tumor, so they can have a safety margin. So when they do the Indian ink injection, the Indian ink, the ink will like absorb and leak to the lymphatic drainage, and it can also go to the inside the peritoneum and be like engulfing by the histiocytes. So you can see these pigmented histiocytes, but these histiocytes are not suggested there is a melanoma. Okay, so this is not uncommon that you can see this type of cell in the colon surgery, because the clinician will use Indian ink to highlight the location of the tumor. So the next one is pleura effusion specimen. The patient had a past history of breast cancer. In this specimen, we see individual as well as cell in cluster with a high-grade nuclear atypia. So you compare the size of the nucleus, and the shape is highly like unusual, looking like a kidney or something like that. And hyperchromasia is very obvious. So this is compatible with metastatic carcinoma and compatible with the patient's breast history. So the next specimen is a ascites specimen. The patient had a history of colon cancer. So this specimen is very difficult to interpret, because in the background we do see a lot of single cells, a lot of karyoresis. So these single cell looks like have prominent nucleoli, but it's kind of difficult to determine if these are reactive mesothelial cell. However, we do see some like a much bigger cell with an eccentric nucleus. This is an individual cells. I think that we can be very confident that this is a cancer cell compared to the adjacent cell. So to me, it's kind of difficult to confirm if these background single cells are also cancer or not, but at least we do have some larger, like highly atypical cells that we can definitely call that this is cancer. So the patient has colon cancer, and he already expired. So this one, I think we can call this positive, but it's difficult to determine. This one we are sure is cancer, but how about the other one? Maybe reactive, maybe some of them were cancer. It's a little bit difficult to determine. So this one is also positive, and seems the patient already has advanced disease, and he is already expired. So we don't need to do any further evaluation of the standing. So the next one, this is also from ascites specimen. So the patient had a history of pancreatic cancer. So this morphology is very typical for pancreatic cancer. We have nice, smooth, luminal border with vacuolated cytoplasm. So this type of like a small glandular cluster with smooth border, sometimes we can see mucin in the cytoplasm. These are highly compatible with the history of pancreatic cancer. So this is positive for pancreatic cancer. Next one, pleura effusion. In this specimen, we also have typical two-cell population that we see a lot of larger three-dimensional cluster with highly atypical cell, vacuolated cytoplasm. So this looks like adenocarcinoma. However, the patient has received the biopsy of the lung, and the tumor was negative for TTF1. So the sign out surgical pathology called this non-small cell carcinoma. So I think it's okay that we just call it a non-small cell carcinoma because it doesn't show the typical TTF1 expression. This is not the pleura. This is pericardian spasm. So the patient also has advanced disease. So next one, this is a urine specimen. We've seen the other specimen from the same patient yesterday. A middle-aged female who has been diagnosed with cervical high CO with microinvasion squamous cell carcinoma. So in this urine specimen, you can still see similar, these high NC ratio hyperchromatic cells look very much like high COs. And we also see some more mature keratinized squamous cell. In this urine specimen, unlike yesterday, we do not see any necrosis area. So this is also that we can sign out as atypical squamous cells compatible with history. Maybe these are necrotic, but it's very difficult to determine. Here again, you see a typical high CO looking cells. So this is compatible with the shedding of the cervical lesion. So sometimes for the elder female, the first initial presentation of a cervical cancer is bloody urine. The patient would think that he had hematuria and go to either nephrology or the GU doctor for the initial survey. But sometimes it would turn out to be cervical cancer. So usually for the hematuria, they would do the urine cytology. So these could be the first like a specimen suggests the patient may have a cervical lesion, so we need to pay attention to these findings in the urine specimen. So next one, let's move to defining the aspiration. This is a patient with head and neck squamous cell carcinoma. During the survey, they find enlarged like a neck nodule. So they do FNA on this neck nodule. He's a 69-year-old male. So they were ruled out if this is a metastatic lymph node. On low power, we see a lot of cell fragment, very tight fragment with three-dimensional architecture. In the background, it doesn't seem to have a lot of lymphocyte. So when we go to higher power, so we can go to the high power to see the cytomorphology first, and we go back to the low power. So when we go to high power, these cells seems to have dark nucleus, but this is very uniform, mostly rounded, arranged in these three-dimensional architectures. Some even show a little bit like a rosette or follicular type of pattern. And because of these chromatin is quite delicate with like a finely powdering like a chromatin pattern, so you may think that these could be thyroid instead of these doesn't look like squamous cell carcinoma at all. Yeah, so this looks a little bit neuroendocrine. So could it be thyroid? However, in the background, we do not see any colloid formation at all. So when we go to low power, we start to appreciate that there are some very complex architecture and also with very slender capillary meshwork. So you see here is a capillary, and the capillary goes through the cellular fragments. So these that we call a transgressing vessel. And there are some more even like a striking area looks like these. So you see nice, like a very complex capillary meshwork, and the epithelial cells are mostly detached, remaining with these like a very delicate meshwork. So this pattern is very common in parathyroid lesion. So these looks like a parathyroid. So these looks like a hyperplastic or adenoma of a parathyroid. So we only need to confirm that if this is parathyroid, but by cytomorphology, this most likely is a parathyroid. So we would do additional staining. So because this is a liquid-based cytology, it's easier that we just do 2 cytospins. So we would do one for GATA3, but because there is no context clinically, I still want to demonstrate the PTH. So I would do the GATA3 and the PTH for this case. But just by the cytomorphology, this is highly classic for a parathyroid lesion. So the next one is also from ENT. The patient has a past history of papillary thyroid carcinoma. So the clinician wants to rule out if there is a recurrence in the lymph node. So this is labeled as left level 4 lymph node. So in this aspiration specimen, in the background, we do not see any lymphoid cells at all. What we only see are bloody background with degenerated red blood cells, as well as histiocytes, suggests that it is a cystic lesion with hemorrhage. So this is highly abnormal in a lymph node. If the patient do have a history of papillary thyroid carcinoma, this is most likely a cystic metastasis. So when we were dealing with cystic metastasis, we still need to identify the metastatic epithelial cells. Sometimes with a cystic change, very prominent cystic change, the epithelial cell can present as a typical histiocytoid cells. However, in this specimen, we do not see any cells that we can at least call atypia. So in this scenario, we are going to call this specimen as non-diagnostic, but we will mention that there is a high possibility that this is a cystic metastasis. So if the patient wants to do a second aspiration and he realizes that is the situation, he can do an additional needle rings for thyroglobulin testing. If the thyroglobulin turns out to be positive, I think the clinician can go ahead to do the excision for the lymph node, even there is no diagnostic cells in the second aspiration. So this is also relatively not uncommon scenario that we encountered. Finally, a parotid gland. This is highly typical. At low power, we already see larger fragments with some magenta color matrix. The matrix has a very close relationship with these oval monotonous uniform cells, and also with a fibrillary type of like characters. So these are consistent with my epithelial cells, and mixed with the extracellular chondromyxoid matrix. We do not see any atypia of these myopithelial cells. So this is a pleomorphic adenoma. This is the most common benign tumor that we will encounter in the parotid aspiration. So this is a typical case. Okay, thank you.